All right. Now you got to get you may not do directions. But we go in circles today. Today we're going to talk about your skeleton. And that's probably key to all of us with prostate cancer. So we're going to do some sort of interactive thing today where we'll be asking questions and get a feel of where you're at, understanding what the issue is all about with respect to skeleton. Let me ask you the first one. What diseases do men and women have in common? Osteoporosis. When do your bones stop growing? Right. All through your life, your skeleton is growing. Not as good when you get older than when you're young, but it's always growing. Your total skeleton turns over completely every 7 years. So at any one time, your body's in a state of repair. Think of it as a building where the bricks are strong, they're very good. The mortar is weak. And it's the mortar that cracks in the bones. So there's weak spots in the bones, little microfractures. And as soon as you get a microfracture, your body has to repair it. And that's the key to the dynamics of the structure. And so bone is living tissue. It's not like a lot of people assume, not living. It's just not a bunch of calcium. Okay, let's go through a few of these things. A negative bone balance leads to osteoporosis. What that means is you're losing more bone than you're making. In this country, these are conservative numbers. 8 million women and 2 million men have osteoporosis. It's actually quite a bit higher than that because we're not really looking for it. And even you see when they get older, kind of limping a little bit, a little hump on their back or a shoulder roll, they probably have osteoporosis and we're aware of it. So those are diagnosed cases. 18 million have osteopenia. It means it's loss of bone. It's not there yet, but it's going there. And we'll get there if you continue doing the same thing you're doing before. 1 out of 2 women and 1 out of 8 men over 50 will have osteoporosis-related fracture. This is an extremely serious disease. The death rate in males in the first 6 months of hip fracture over the age of 65 is about 50%. So this is a very fatal disease. Easy died of pneumonia. You're very depressed.
From the osteoporosis?
Pardon?
The death is caused from the osteoporosis?
No, pneumonia is a cause of death. If you fracture your hip, you become sedentary, you lay still, you get orthostatic hypotension, your immune system fails, probably with depression, and then you die from pneumonia. It's a very common death in males. Women do a little better. It's responsible for 105 million fractures per year. I mean, look at the numbers, 300,000 hips, 200,000 wrists. This is just picking something up. Vertebral is extremely common, 700,000, and those are usually just compressions. The person will do almost nothing, all of a sudden it feels pain in their back, and they have a problem. And other fractures are other long bones. So this is a very, very serious national problem that we really have not been addressing very effectively until very recently, particularly in males. The best work done is in the females. Bill, you got your board ready? Okay, now we're going to look at things like what are the risk factors. You want to talk about what's a risk factor?
Probability.
Yeah, probability. What's the probability of you getting osteoporosis?
50%.
Okay, but give me a reason though.
Testosterone.
Adequate calcium intake.
Calcium?
Low calcium.
Okay.
Low testosterone.
Low testosterone.
Bad diet.
Low vitamin D.
Low vitamin D.
Exercise.
Lack of exercise. Good one. Very important. This is one that's usually overlooked. One of the most important single factors is lack of exercise. When people get older, they get a little stiff. They don't feel like walking. They don't feel like exercising. Therefore, they don't do it. It really contributes very heavily to the problem.
Just want to be first with low calcium, then the second with what? Low what?
Testosterone.
And testosterone. Okay. When you get older, your testosterone drops. So that fits it. What about a person who has an androgen deprivation therapy?
Yeah.
Almost 100% will have major bone loss. Actually, 100%. We know, but
How many people in this room have or are going or have been on hormonal blockade, androgen deprivation therapy?
Pay the price. Anything else?
Extremely low fats and oils in the body.
Yes. And why?
Intestinal absorption.
Yeah. And you don't absorb well without enough lipids and fat in your diet. That's an issue for us to try to do low fat to slow our tumors down. Let me tell you a test you can do. Take your fingers, put them around your wrist. Can you touch your fingertips? Whoever can touch their fingertips has a medium to small build. If you can touch a knuckle with your fingers, you have a very small build, and you tend to get osteoporosis much more easily. Now, if your fingers won't touch, you have a heavier frame, you're less likely to get osteoporosis. So, right off, you can look at your risk factors, and that's why women have much more osteoporosis than men. One of the reasons, their wrists are smaller, but their whole frame is smaller. Men have a heavier frame. So let's break this list open. Those written down a bunch of stuff here. Let's just go through here. First thing that we talk about, small frame, advanced age, family history. Sometimes it's just in family. You see, picking women, they'll get hung up in their back quite early in their life. So they have to really pay attention to it. Being a Caucasian actually causes loss of bone. Just being a female tends to make it higher. Early menopause also needs it higher for female. Cigarettes are a real risk factor for osteoporosis. People smokers are unaware of that. Low testosterone levels have been mentioned. Very inactive lifestyle. The older you get, the more you got to move. You got to keep moving, or you're going to get a problem. Alcohol is a terrible problem. So if you look at this list here, in our society, someone's got one or two of those risk factors. Hardly anybody has none of them. I know. It's just the way we live. Now, bone integrity, prostate cancer is a critical issue because if this tumor is going to go anywhere, it's going to go to the skeleton when it leaves. 90% of these tumors that metastasize somewhere else are going to go in the skeleton. And Bill has one skeleton, that's I have 5 or 6 or whatever you want to call them, they go up and down. But that gets to be a serious problem, it's very difficult to treat. So think of your bones are your structural framework, but in the bones, that's where your marrow is. All your red and white cells. Your immune system actually is in your bone marrow and under your skin. So it's critical. There's a lot of blood vessels in the long parts, the hollow part of the bone. And that's one other reason tumors like to go there. There's a lot of growth factors. There's a lot of reasons for tumors to like to get the bone. So bone metastases is not primarily in the bone to start with. It goes to the blood vessels, attaches to them, and then works its way up to the bone and starts to break bone down. So here it is. Prostate cancer spreads preferentially the bone, leads to bone metastases. Pain is a real problem with us with prostate cancer because it does two things when it goes to the bone. It's contrast to, say, breast cancer. First, when it goes in the bone, it causes the bone to break down. And that's not painful. It's just very silent. And so osteoporosis is called a silent disease. Secondarily, it turns on bone growth. You think that might be good because it's going to repair those areas that are damaged. It doesn't go to the damaged areas. It goes elsewhere. So it'll grow along the bone and start to grow on the surface. And then it'll press in your muscles and cause pain, a lot of pain. Anemia, almost all patients who get bone metastases have anemia. That's a low red count. Low red count takes saps you from your energy and makes brain function much more difficult. And we know that clearly anyone with anemia, regardless of disease, their life will be short. You have to correct it early. Fractures are common, but they heal. Spinal cord compression is very serious. The vertebrae will start to collapse and will compress over the cord and then you get partial paralysis. So it's a condition that if you have any possibility of avoiding it, believe me, do it. And pay attention very carefully to the things you need to do it.
Is that why you get shorter as you get older?
Yes. Your vertebrae will tend to collapse down and you'll actually lose something as much as an inch a year. So when you go home, go by the door, you might make a mark there and you may be a little surprised and find that you're a lot shorter than you thought you were. Some people lose up to 2 to 3 inches in 1 year. It's quite amazing to do. Okay. In bone integrity, which means the ability of bone to function and be normal, androgen deprivation therapy by either removing the testicles or taking a drug like Lupron immediately causes bone loss. So what you have to do there, one's going to go on androgen deprivation therapy, is at that moment start to correct it. Don't wait until the damage occurs. And I hate to tell you this, but most physicians would love to see you wait until it occurs. And, oh gosh, you got osteoporosis. That's what happened to me. And that's definitely not the way to deal with this disease. Earlier is better. The process of bone loss releases all these growth factors. And there's a lot of suspicion. In fact, much research data is showing that this is why this tumor goes to the bone. So actually we're creating a condition by taking a treatment to keep ourselves alive. So we have to know that. And when we know that, then we have to take some sort of action against that. And up front, not to wait. Don't wait until the clear-cut signs, because it's difficult.
What about intermittent hormone treatment? Is that,
Okay, one of the advantages of that is that regardless of what any physician says or understands, or the clinical trials say, because they cannot show that you'll live much longer if you have an aggressive cancer, but you'll live a much better quality of life. If your testosterone comes back, your bones will tend to repair. And I think that's one of the main advantages of when you get the hormone blockade. But to a physician treating cancer, I don't worry about that. I'm only worried about the cancer. But we have to worry about the quality of our life. So we have to really carefully pay attention to that. Okay, how are you going to evaluate? Find out whether you got this disease. What are you going to do?
Bone density test.
Pardon?
Bone density test.
Bone density. It's the #1 test. So, if you're going to go on androgen deprivation therapy, on day 1, before you start that therapy, you get a bone density done. Women have been doing this for years, by the way. Men have to learn how to do this, and they have to do it. It's a very simple test. Every year, you should have it done. You might be shocked. Most people don't have a baseline. They have no idea what they start with. And they start with osteopenia, and they take androgen deprivation, and then quickly they're losing bone within a year. They have serious problems. It's called bone mineral density. Very simple test. You lay down, it has a scanner over you. Make sure you get a copy of that scan. Have it in your file so that you can follow what's happening. Okay, do it regularly, and that means at least once a year. If you have osteoporosis, maybe even more than that. What's the simplest test you can do to see when you're getting in trouble? This is an expensive test. Something really simple. Go home, stand by the doorway, mark where you're at. As you did with your kids when they were small. Same thing. As they're growing up, you'll be shrinking down. Simple test, but it works. And I recommend you do it when you go home, even tonight. You might, and look in your records as to what you were a few years ago. You might be a little surprised. Here's what this density thing looks like. And what you measure is your spine, because that's a common place to lose bone, and that's the vertebrae there. And then you measure the height. So, that's upside. The femur here is upside down. So I turn it over. These lighter areas here are where there's less bone. Here's where there's more bone. You measure. I do carefully measure the height of this side and the height of that side. See if the vertebrae is kind of collapsing. Because when it does that, it'll squeeze the disc out, and you're going to get a lot of back trouble. And this is a nice straight back.
Is that what the bone density scan does?
That's what that scanner picture will look like, and you'll get a copy of that. And then they'll have here a plan about how the density looks compared to normal. And there's 2 scores, there's a T-score and a Z-score. T-score is the actual density of the bone. That's what you want to know. You don't be so concerned with how you are compared to every other 7-year-old. You want a skeleton like a 30-year-old who can do it, and try to get it there. And the important one, as far as I'm concerned, is the hip. Because the hip, as you get older, when you compress your vertebrae, the machine will see that compressed vertebrae as more calcium and give you a better number for the spine. And that'll be I call it an artifact. And the hip, on the other hand, this bone right here at the surgical neck of the femur, this is upside down. That's the ball socket up on the top. And this is the intermediate part here, and this is your long bone. This area here flexes more than any other part of your body. It has to say 250 pounds per square millimeter every time you walk. It has to move. You lose bone in that area, you'll tend to fracture. And so this is the area you want to watch. Be very careful, make sure that's okay. And the other area you want to look at when you have a bone density is look over in here, look into the capsule. This person getting close to bone on bone, and they're going to get in trouble if you allow them to get the bone. And that's a cartilaginous issue that has to be looked at and pay attention to, otherwise you get up with a problem. The test is called dual DEXA, and it's a dual X-ray with a standard, and they can measure any part of your body you want, but generally the test measures the lower part of the spine and the hip, but now they measure both hips. And they're very surprised to find out to measure the right hip, and they look perfectly good. Mine looks great now. My left hip looks pretty bad. I thought it was good. So by comparing the two is very important. That T-score, which is your actual bone density, is the one that you want to have evaluated. And you want to look at. The Z-score is your relative status for other people your age. I wouldn't bother with that so much because most people your age have got a lot of bone loss, and that's not your goal. This is just a picture of what this looks like when in the skeleton itself. When you have a little fracture, like right there in the bone, the body will start to call in what I call purple people eaters. That's about how they look under a microscope. They have this ruffled surface, and they'll come into the area, and they'll dig a pore, they'll dig a hole. So it's like digging the plaster out of the wall between bones. Is the same as what you do is you take the mortar out between bricks. You clean it out, and then the second cells come in here. These are osteoblasts, and they'll lay down matrix in there and repair that bone. That's the normal way your body does it. But prostate cancer, unfortunately, the hole will be dug in one place and the bone will be put on another. And where that hole is where the cancer will go, into the pore. So that becomes a difficult issue to treat. There's not really any definitive treatment for that sort of situation. So what can you do? Medication you can take. Fosamax and Actinol. These are bisphosphonates. They're phosphoric acids that go in the bone. They help the bone link up and tighten, and they shut down the osteoclast. Fosamax and Actinol both are pretty good. They're very poorly absorbed. They're oral medications. You want to be extremely careful when you're taking these. You have to be rigid in the way you take this drug. You take it in the morning, and you do not lay down for 1 hour. This is a half hour, I say an hour. You make sure you stay upright, no coffee, nothing but water. I recommend it when you take it in the morning, go take a walk, half-hour walk. Put some pressure on your bones. And see, the bones are crystals, really. And you pressure these bones a little, they'll tend to pick up calcium. So go have a good walk. About an hour later, then eat your breakfast. Do not drink coffee with this. A lot of people do, and they get gastritis right away, and they can't take it anymore. So either one of these drugs is very good. They have such now that you can take it only once a week, if you want to, or every day, and it's fine. But if you have a more severe problem, there are two other bisphosphonates that are given intravenously. The first one I would just ignore completely. I would not take Urea under any conditions. I would take Zometa, which is a new drug. This drug is 10,000 times more powerful than any of the oral medications or any other medication that we have out for bone. It's a once, for a cancer patient that has metastases, that's a once-a-month infusion. It's 15 minutes. Doesn't make you sick. It's very nice, actually. For women, 4 times a year will prevent osteoporosis. Looks like it'll do the same for men, just in the clinical trial. So where the future is going to lie is that those that get ADT treatment, they'll take this with their treatment and prevent the condition. It maybe prevents skeletal metastasis.
Is that somewhat automatic when you go on ADT to take one of the pills?
You mean like just someone will give it to you?
Is it standard?
No, it is not. Doctors do not prescribe this to patients, except when the patient insists on it. That's why I think we're having a meeting here, because I want you to know, if you feel you need it, you tell your doctor, I need this. And he'll say, well, we only give it to women for breast cancer or some other issues. You know, I need it just as much, and you do.
How would you determine whether you needed it unless you went through this bone density?
Well, that's what you do. You see, you get a baseline bone density. But, as I mentioned, this baseline bone density is your starting point. Now, your doc might say to you, well, let's take the treatment and do a bone density a year from now. And I guarantee you, you'll have bone loss. You say, no, I'm not going to do that. I want this treatment now so I won't get the bone loss. It's called proven principle. They'll say, well, can you prove it? And yes, clinical trials will prove it. And if they haven't read the literature, it's not your fault. That's their fault. They have to do this. I've been going around the country talking to groups, doctors, patients, and say, listen, the patients that will drive the doctor will not drive the patient. They won't do this.
So there's as much conflict with this as there is with treatment of the prostate cancer itself.
Yes, maybe more so. But this may be as important as the treatment for prostate cancer. Equal, or maybe more. What these bisphosphonates will do is, I'll make it as an example. We know now in the laboratory, it will kill prostate cancer cells. It will stop osteoclasts from functioning and probably stop osteoblastic reaction. It's like a miracle drug. And I call it penicillin. But the doctor will say, well, we have to wait 5 or 10 or 20 or 30 years. They don't have cancer. They haven't got the problem. For them, it's a financial issue. And also insurance companies. I don't worry about that. We have to get the therapy. So we have to speak up. And you really are going to have to speak up. And the doctor will say, you don't need it. And many guys will come and say, well, I said I don't need it. So get another doctor immediately. And let your doctor know why you're going, why you're leaving. Because you do need it. And I think we need doctors who will do it. And get on with your treatment. Because if you don't, be sorry. Long run. I'm telling you from experience. We were just talking about what some of us are doing. Judy Golesh, Russell's wife, now she's taken it and taken Actimel, and she's now taken weekly, once a week, Actimel for her osteopenia, so she will not develop osteoporosis. She's also walking. And Russ is a virtual athlete, and he's still taking it to make sure his skeleton doesn't get worse. He's doing this to prevent skeletal metastases. Bill here is taking Fosamax, was taking Fosamax for a long time. How many years did you take it, Bill?
7 years.
7 years, okay. And
What's
now
the side effect, or what's the downside
of Fosamax?
of taking it?
There's a theory. Someone says, boy, you make your bones too hard. Possible. There's no evidence for it. Zero evidence. But you can scare anybody to death, you know. Not taking it, I can tell you what will happen. You lose your skeleton, so you better worry about that part of it.
So there is no downside.
There is no such thing, but anyhow, I would be talking to you about that has no downside. The responsibility that one has to take for the treatment is the patient takes the responsibility whether they like it or not. So 5 or 10 years from now, someone might want to say, you know something, you made the skeleton too hard, made it brittle. I don't think so. I think the only thing I know that will do that is chloride, which we have in our water every day. That'll really harden your skeleton up. But we can't avoid it unless we take the chloride out of our water. So Bill's got lesions. His lesions have not progressed. Very good news. I have multiple lesions, and I haven't got my scans here with you, but I can tell you, I took Aredia for about 2 years, almost 2 years, and my skeleton lesions got a little smaller, but they didn't go away. I didn't have pain. When I went in Zolita, within 3 months, my skeleton, my skin became complete. Now I have some back, but it does tend to treat your lesions more effectively than any other drug that we know of, at least at the present time. This whole area of looking at bisphosphonates and skeletal metastases has been going on now for almost 20 years. Most of the data comes from Europe. The United States, really, doctors didn't want to believe that this would do anything. So we're finally coming up to speed now. Okay, now let's go back to some of these issues. Bone growth and loss. What promotes bone loss?
Loss of calcium.
Loss of testosterone.
Loss of calcium, loss of testosterone. I want to review this with you. This is very important to know. Because loss of calcium is dietary. If you're not eating a lot of green vegetables, you're not getting enough calcium in your system, I'll tell you. If you're a meat eater, God help you. Protein binds with calcium and sucks it right out of your system. If you're drinking milk, you suck it out of your system. And regardless of what the milk industry says, they put vitamin D in it. They do not put vitamin D in the milk. That's a lie. What they do with milk, they run it through and they irradiate it with light, UV light, and it's supposed to make vitamin D. The government is not required to check to see how much vitamin D is in there. And that vitamin D it makes may not even be absorbed in the body. There's no evidence for that.
I read somewhere you get enough vitamin D by spending 5 minutes outside.
15 minutes in the sun, not 5. 15. 15 a day. If you do not have a malabsorption problem, definitely you would probably be right. And that's why people in the southern climates have much less ovarian cancer, prostate cancer, breast cancer, and colon cancer. All of those 4 cancers are related to vitamin D deficiencies. So you're right on that point. But very often as we get older, we have malabsorption. Vitamin D, when your body brings it in, it has to convert to several steps to make it active. And the only way you can find that out, which I recommend for everybody who has prostate cancer, get your serum vitamin D checked. You might be shocked. The average serum vitamin D of a cancer patient in the north is 26 picomoles per liter. Minimum is 40. We're way below it. You've got to bring it up to standard. And you can.
Is soy milk okay for calcium?
Pardon?
Soy milk, does that give you calcium?
That's okay, yeah. But I think you need a lot of green vegetables, so you need to help get it into your system. And you'll need to actually, if you're going to do the calcium, then you'll need to make sure you get some magnesium in your system. Your bone is primarily magnesium. And if you take only calcium, you'll displace magnesium. And your heart function you might get some arrhythmias in the heart.
Bill, isn't too much calcium bad for the heart?
It's a big, tough issue. There's been one study published by Giovannucci, actually 2 studies by Giovannucci, showing that men that have a lot of dairy products have much more aggressive prostate cancer. I talked to him about it, and I can't believe he didn't do this, but this is what happens. He didn't measure the vitamin D in his serum. And I said, well, there's been many studies to show that one goes with the other. But so if your vitamin D level were high enough, you're probably all right with that calcium. If your vitamin D is low, that calcium can go to the tumor. And that's another question, by the way, on point. If you're taking calcium, take it at nighttime. Don't take it during the daytime. It goes to your kidneys in the day, it goes to your bones at night. Take it before you go to bed. And eat the meal before you go to bed. Okay, let's just break loose and take a look. You guys are pretty good, I think. Not enough exercise, we talked about that. Loss of androgens and estrogens. Estrogens, by the way, may be even more important in males and both males and females for building your skeleton. That's why eproflavone, which is a soy extract, actually builds bone. Deficiency in calcium, boron is very, very important in your system. In vitamin D, in steroids, you've got to be careful about it. Progesterone is also a problem. Lupron and Zoladex. So the things that we have to do to stay alive actually can cause us a lot of problems.
Bill, I thought I heard that a lot of soda or sugar will also cause osteoporosis.
Sugar's terrible. Sugar causes bone loss almost instantly. And the reason for that is the sugar, it displaces so many metabolic systems in your body. But along that line, though, sugar is a problem, but protein is a problem. If you're drinking milk, drinking regular milk, and you want to skim milk, protein concentration is higher, actually pulls calcium out of bones. People get upset. I mentioned that. I can tell you that the highest cancer rates in the world, and the highest osteoporosis rate in the world, Switzerland and the United States, where the big milk tumors. And so that's what Giovannucci's thing is. Hey, we've got to look at this very carefully.
And chocolate.
Pardon?
Chocolate.
Yeah, milk chocolate. Yeah. Okay.
That is okay.
What promotes bone growth? What makes these bones grow well? Exercise. Get that one done, though. Critically important. One thing we tend to overlook: exercise. Simple and exercise is walking and bouncing your bones helps. Exercise is number 1. You need to have weights. I'm not talking 20, 30 pound weights. I use 5-pound weights. Just take some weights and look at that. Makes the bones flex a little bit. They're like a flexible, like a bridge. They start to build up. Okay, anything else? I'll think back to the other thing before we talked about androgens. If you've taken away too many, And for many men without cancer, androgens are being given to them to actually build their skeleton up a little bit. Estrogens are also very effective. Calcium, vitamin D, and boron.
What's boron?
Boron's a mineral.
What do you boron take for?
In your diet, it's hard to get boron. It comes in, again, from vegetables. I personally recommend you supplement if you have cancer. I take 3 milligrams a day. And boron has some very strong anti-cancer properties as well.
Like boron supplement?
Yeah.
Yeah, you can even get it's formulated in like calcium, magnesium, boron, and zinc.
Yeah, and that's good. And as long as it's low, and you want to stay low in copper, you need manganese too. There are formulations that have all this stuff in
Of
called
course, you're taking your calcium, but it doesn't mean it's going to be deposition of it unless you have these other minerals.
and silicon. You need silicon. Both are very complex structure.
On the day you take a flaxen so you can't do any minerals or calcium or iron those days because it affects the work of the flaxen. It won't work as well if you
I
take
don't think
minerals.
that's what
It
it's
says so in the literature.
Pardon?
It says so in the literature.
Well,
That particular day, the iron and everything that pulls out.
iron,
it's
see,
just
iron's
that-
different. Now, see,
that- and
iron's
calcium,
not like calcium.
copper,
Iron,
all the minerals. don't
iron will
take it.
suck out calcium. It's a chelating agent. Calcium, actually, which all Fosamax does is turns off osteoclasts. It doesn't do anything else. And what makes calcium go in your bones is vitamin D. So it's a different issue. And they're probably saying not to take it together. I think mainly I would say iron. I wouldn't take. I'd be very careful on iron at all.
Well, particularly on that day, more so than anything, when you're taking the tablet, you do it once a week. That's
But
what it says.
but for cancer patients, I don't know.
I read that we can only absorb like 600 milligrams of calcium at one time.
It's maximum absorption. I don't think you can absorb that much. I think you only absorb, depending on what you're taking, carbonate maybe 1%, and citrate, malate, and tartrate you'll absorb a little bit more. But that's correct. About 600 milligrams a shot.
Well, then you can't take all your calcium at bedtime if you have to get it hard.
No, that gets to be another problem here, which needs to be really expanded. Most people will take calcium and without asking the question, are they getting it into their system? And so they'll look at their serum calcium and say, well, it's normal, it must be getting it in. Your serum calcium will never reflect the amount of calcium you're taking in if you have a normal parathyroid. You need to measure urinary calcium, and you might be quite shocked. My vitamin D levels are raised up fairly high, and I take 1,200 milligrams of calcium. My urine calcium will go up to 350 picomoles. If you do that for about 4 months, you get stoned. Some people just don't absorb calcium, so you have to check that out. Your best bet, if you have to get 1,200 milligrams, I don't understand that criteria they have out. If you're eating vegetables and you're not a heavy meat eater, you're probably getting 1,200 milligrams, almost 1,200 milligrams from your vegetables. So that fixed number they come up that you might need, I think is artifactual. I'd check it out very carefully.
Tony, what is the situation with calcium? That can't be monitored.
Calcitriol is extremely important to monitor, and the way you monitor that is your serum calcium plus your serum vitamin D. And some people can take more, some cannot. I can't take 0.5 micrograms indefinitely. I got to back off from 0.25. You got to tailor it to your system, and each one of us is a little bit different. And again, this is a problem you have with your physicians. They would love to believe that we all look exactly like, we behave exactly like, and we respond exactly like, and I guarantee we don't. We're very different, and we have to understand and make use of that. And just forgive our physicians for not looking. We need to collect that data for ourselves. So you need to monitor your uptake. So is it doing you some good? So that essentially what you need to do to promote bone growth. And again, we can't emphasize enough exercise. I didn't smile to start with. Any questions on this?
If you're taking green vegetables, you still recommend a calcium supplement?
Yeah, but I don't think, to tell you the truth, that the 1,200 is realistic. It's too much. And, one thing that's a big worry when you get older is calcification of blood vessels. That's a worry. And I think that's excess. But I would find out whether I'm doing all right by A, your bone density, height, and every now and then checking your serum vitamin D, and checking your serum calcium should stay within a very tight range. If it's running out of range, let's say your calcium drops down, like the condition I have, it's called bone hunger syndrome. And the tumor will suck up the calcium, lost calcium, and it'll take it right out of your skeleton, and then you get bone hunger, and that's when you get a lot of pain and muscle contractions and things like that. So that means the parathyroid gland is really not working, not doing its job, balancing it. So it balances it to very, very close range. Because if it goes up too high, you get trouble. If it goes down too low, you get trouble.
You want to be about 10?
Yeah, 9.8 to 10, yeah. I like to keep my little on the high side. And now with breast cancer, because it's very common, since breast cancer is only breaking the bone down, it's losing calcium, and the serum calcium will drop. Watch very, very careful. Multiple myeloma is the same way. Prostate cancer will be less. You're building it's sucking up calcium.
What do you want to tell them about pyramid speed?
Well, you know what? The best way I think to measure all of this is a urinary test called pyrrolate speed. And you can do that, or another test called telopeptides, C-telopeptides. It's a serum test. There's a new test coming out with saliva. But all you have to do with the urine test, it's a simple test. It's a second void in the morning, a small amount. And if your DPD levels, and DPD is a linking agent between collagen fibrils. And when you link those two collagen fibrils together, that's what bone is. It means your structure. So when that starts to leak out in your urine, that means you're losing bone. So if it's over 5.5 picomoles, you're losing too much bone. It should be below that. So if you're, say, you got 7 or 8, you're getting bone loss. And then you want to check your vitamin D real quick in your serum, make sure that's all right. And then you raise your serum, your calcium up in your diet.
Is that a normal, do they do that when they do the urinary test?
Never. Doctors don't even know what this test is. I can tell you, 9 out of 10 doctors will ask you what you're talking about. You have to inform yourself and educate your doctor. And again, forgive them for their ignorance. They do not know. They don't know what telopeptides are. Never heard of them. See, they're specialists. They did not learn anything about bone. No one ever taught them. When they went through medical school, I taught medical school, they get their time on bones about 1 hour lecture, that's it. And if they don't read the books, they're not going to find out. Most doctors I know don't crack a book once they're out of practice. They're too busy. They really are. And so they don't read. And this is a revolutionary change in the way we're treating disease now. Multiple myeloma patients 3 years ago, 100% were dying. They're all living now. Because several friends of multiple myeloma and several physician friends are back to work. They were dead. With Somita, they're staying alive now. So we can understand this is a serious, serious problem. We should have known a long time ago because women with fractures was just an overwhelming problem. And we just assumed it would never bother men. And as the old days were, women would never get old because they had estrogen. This nonsense. We believe in silly things. Now we know what we have to do. We have the drug to do it with.
You know, wouldn't a treadmill give you the bounce on your bones for promoting the bone joint?
Treadmill's good. I use a trampoline. Bounce on a trampoline. That's good too. And treadmill's good.
Scares the hell out of people.
Oh, I got a little 36-inch job in this kind of. I don't bounce very high. It's going to bounce and then walk. They'll all do it. There's a lot of good ways of doing it. And then you get some little weights and do some arm weights. Upper part of your body doesn't fall apart. And yoga is extremely good. Yoga's never good osteoporosis. They stretch.
Walking up the stairs.
Walking through is great. Part of your knees though. But it works. There's so many things you can do that, and just think about when you were a kid what you do, and then you do some of those things you find. There's not really a downside to exercise that I know of, except maybe traumatic exercise, running on cement and stuff like that. Just not much. You don't have to do much exercise. Half an hour a day is fine. Many people I know don't do 10 minutes a day, 5 minutes a day. And I don't care if they're in perfect health, they're going to end up bad health and impact. Diabetics, by the way, I have many diabetic friends with insulin-resistant diabetes. The most important single thing they can do is exercise. And for us, by the way, exercise is critically important for our survival because what when you don't exercise, you eat a meal of carbohydrate, and your insulin growth factor will welcome your serum. This is how your tumors grow. If you exercise, that insulin is going to go to your muscle and build muscle. If you're not exercising your muscles, it's going to go straight to the tumor. And in fact, the study just done, it's quite remarkable. It took men that were obese and inactive, and then they had in a tissue culture plate human prostate cancer cells growing. And they took the serum, what's known as the cat. They took that serum out and added the serum from the human, the inactive human, versus another group, which are the same inactive people, obese and inactive, exercise them for 10 days and put them on a diet, restricted diet, restricted their carbohydrates, and they restricted elevated their fiber, and restricted their fat. And the group that was obese and inactive, the difference in cell death was like 5-fold. So they said, well, this is really strange. What about people who've been in good health for years? It's even better. So that what it says, at any point in your life, you can take action and probably limit your tumor just by moving. And but what happens in most cancer patients, they get a little bit depressed, they quit moving. That's one of the problems. If we look at long-term survivors, we look around, they're moving all the time. And the people who just don't do anything, they don't make it. So keep moving. It's good for you.